her abductors of her right shoulder, and then some tightness within her scapular region. And so I want to have two people come up. We're going to talk about the muscles of the neck.
63-year-old.
You guys? Huh?
The neck.
The neck.
On the neck, okay.
And we're
Right,
not on
Josh?
the legs yet.
All right, let's go. Josh. Yeah. All right.
Oh, we got
Let's
two
go.
ready to go?
Oh,
Let's go.
yeah. Better. Are we switching or did we do it?
We're all, yeah, you guys are all gonna get a turn. Okay, so now, you have to do like you would if you were going to go through the practicum. So you're gonna have to tell who you are, what you're doing, like you're gonna wash your hands, and then you're going to take them through the range and do the palpation, and tell me what the nerves are, okay? So the first one is the upper traps.
I'm the 63-year-old patient with a.
Yeah, you're the 63-year-old patient. I can't say female. You're the 63-year-old. Okay,
Good?
good.
We'll wash my hands. Okay. Hi,
Okay.
Boo. My name is Jose. I'm a physical therapist assistant, and I'm going to be working with you, okay?
Hi, Jose.
All right. So,
So don't look at me. That's your
Okay.
patient. So your patient is having difficulties with cervical extension.
okay.
So tell me, what muscle are you gonna work on with him, and how are you gonna palpate it?
Okay, so for cervical extension, we're going to be looking at the upper trapezius,
Mm-hmm.
and
Okay, so I want to know what the optimal position is that you would put your patient in.
to palpate.
Mm-hmm.
Okay, so we're gonna put you prone. So, does this come off?
Mm-hmm.
Okay, go ahead and lay down for me, face down.
Yeah. Ooh, looks happy.
Usually, usually you put something right here, right?
Mm-hmm.
Okay,
Okay, you wanna,
yeah. So go ahead and lift your feet up, alright, put them down. Okay. So for the upper trapezius, so we know the trapezius, insertion is in the, lateral 1/3 of the clavicle following the acromion and then spinal scapula.
origin?
The origin is the occipital protuberance, and then the medial portion of the nuchal line coming down to C7, and then going all the way down to T12.
Upper traps?
For the upper traps?
For the upper traps. You
Yes.
just told me you're gonna do the upper traps. So we're not doing the whole trap, we're just doing the upper trap.
Okay, so C7.
Okay, okay. All right, and what would its nerve innervation be?
Accessory nerve and then the ventral ramus.
And then accessory nerve what?
Nerve 11. Facial.
Yeah.
Wait.
Yeah, no, it's 11. So
So,
if it's facial,
no, but it's
facial.
like, it's the, one of the nerves.
no, I know that, but facial tells you where it's at, right?
Yeah,
Okay, so accessory nerve 11. Don't second guess yourself.
that's why I got it right.
Yeah.
Okay, so that's gonna be for the upper traps, and then,
Mm-hmm.
what else did you need?
I want you to palpate it.
Okay. So we're looking for the spinal scapula. And then C7, so you're looking at that's gonna be C7 and then nuchal, so you're looking at this part right here.
Mm-hmm. Okay. All right. And what does it do?
Extension of head and neck, lateral flexion to the side, and
And
then
what else?
neck rotation to the opposite side. Rotates the neck.
What else? We do it all.
Upward rotation of scapula. And then scapular elevation.
Scapular elevation. Okay. Okay. Good job.
You want the rest?
Your muscle is only Okay, so now, when you're looking at, yes, we can go through the whole muscle, but the problem was just the upper tract. So if
I was
on
just
your,
messing around, I know.
yeah, so if on your test question you get, I need the upper tract, I just want the upper tract,
Okay.
okay? And because the middle tract does something else, and I might want just those origins. So, but you did a good job. Okay, so now, that same patient who's having problems with elevation and extension is also having an issue with abduction of the right shoulder. What muscle would that be? The deltoid. Okay. So, I need two people to do the deltoids. Do I need to double dee? Okay, Damien, Bryce.
Do it, baby. So we're doing abduction?
Yes.
Okay. So I wash my hands. Hi Damien, I'm Bryce, physical therapist assistant today. Are you having problems with raising your shoulder to the side? Yes, I am. Can you show me that real quick? Which one? This one right here. Make sure your thumb's pointing to the sky. You raise it up just like that. Hurts right there? I can be a 3 minus, right? Is that 3 minus? Do you want me to palpate it now?
Yeah, I want you to tell me origin, insertion, action of that muscle, and then palpation.
Alright, so the deltoid inserts at the deltoid tuberosity, and then it originates from the spine of the scapula to the acromion, and then the clavicle.
What portions?
So the lateral 1/3 of the clavicle, and then the spine of the scapula to the acromion. I'm
Okay.
guessing the lateral, the 1/3 of the scapula too.
Okay.
Then it goes down all the way like this, down to the deltoid tuberosity, so it's this big like triangle shaped muscle.
Mm-hmm.
The nerve would be the axillary nerve,
Okay.
and then the action would be abduction.
Okay. What else can that particular muscle do?
The delt.
Mm-hmm.
The front fiber, anterior fibers would be flexion. The posterior fibers would be extension.
Good. Okay, Damien, I want you to do the palpation on him. All right, go ahead. No.
Alright, so I'm gonna look for,
Say ding.
Gee.
sorry about that. Just for your dance.
I'm back next year.
Okay, so I know the deltoid is.
Okay, so to make it easy for you, you can palpate the particular fibers. So you're not going all over, you know?
So I can start here. This is the anterior deltoid. So if I want to make him, if I wanted to come out more, I would have him raise his arm, abduct his arm.
Okay, and what position is his arm right now?
Right now it's abducting.
No, what position? You gotta make sure that you put it in the right position, otherwise the head is clunking up against.
And here's the anterior deltoid. And here's
What's that considered?
posterior deltoid.
Uh-huh,
And then the middle.
okay. Yeah, we're not doing manual muscle learning. That would be an Omar.
Could you push down and have them like fight against you to make it pop more or no? Or is that like?
I mean, you can, but why? It's already activated when you move it. So, yeah. Good job, guys. Okay, so now, you're still having an issue. And so you're thinking it might be a muscle that's deeper than the deltoid. What muscle would be deeper but yet does the same action? Supraspinatus. Okay. Trevor and Dean?
Ooh, let's go, G. Let's go, Trevor. And go T-Raw. T-Raw.
We're doing the super spinatus?
Super Spinatus, you got it, Dean.
Come on.
You know that one already. Is that the one that's hard for you, Dean?
Yes, ma'am.
We went over it.
Okay,
right.
but it's easy because guess what, Dean? Isn't it a part of the sense muscles?
Yes.
Okay, so, the SIT already connects to the same, all three of those connect to the same
greater
area.
tubercle.
All right, so then what would its origin be?
For the super spinatus?
Yeah,
The lesser tubercle.
the origin?
Oh, wait, no, the subscapular fossa. Wait.
That's, come on,
Super-
Dean,
No, the
it's
super
super.
spinous fossa.
Okay, so,
Oh, my
okay, so Dean, what I need you to do, this is why we're doing this, right? Because you see how nervous Dean is, and he's already missed two,
I know.
already. And he
Yeah,
already,
come on.
and he knows it, right? So we want you to be confident, woosah, bring it down, it's okay, right? Take a deep breath, let it out. And then when we ask you the question, just think about it. You have time to think. We're not doing this to you, okay? And neither will your patient. So when you come in, you just do everything that you need to do, wash your hands, introduce yourself, and then let him know what you're gonna do with him, okay? So as you're talking to him, you can be telling us the supraspinatus runs from this point to this point. So that's why I'm going to be palpating on this area of your body, because this is where the muscle is. And I would like for you to go through this type of motion in order to activate that muscle so that I can feel for it better. Okay? And so that makes it easier. Your patient will be comfortable with what it is that you're doing, and you'll be comfortable. Okay? All right. Ready to start over?
Let's go, baby.
You got this.
So I wash my hands. Hi Trev, I'm Dean, I'm your PTA.
Hi.
Today we will be checking out your supraspinatus.
All right.
So I know that the supraspinatus, it helps with abduction of the shoulder, or adduction of the shoulder. And
Supraspinatus.
yes,
Does AD or AB?
adduction. Yes.
What's this?
Internally rotates. It helps with internally rotation, and it helps with
And what's this motion?
that is abduction. So it helps with adduction of the scapula.
AB or
Adduction
AD?
of the scapula.
Okay, so which direction is AD?
In. Or well, AD is of the shoulder is down.
Right, so
Yeah.
then supraspinatus does what movement?
The muscle runs from the suprascapular fossa to the humerus, right? The tip of the humerus here. So if it contracts, it's going to do what?
Abduct.
Yes,
Okay.
okay. A is the AB.
Mm-hmm. And then, do I have to give you the origins and insertions right now?
Yeah.
Okay, so the supraspinatus originates at the supraspinous fossa of the scapula, and it inserts at the greater tubercle of the humerus.
That's good. Okay, Trevor.
What?
Tell me, what is the nerve?
Nerves are C5, 6, and 7.
And the name?
I don't know the name. I
Is
know
it
them by the
ax-
C's.
Is it axillary?
No,
No.
Oh,
axillary is here.
Isn't it the supraspinous nerve?
Scapular.
Yeah.
Suprascapular.
Suprascapular. Okay.
Okay, that's good. All right, so Dean, can you tell me again what the supraspinatus action is?
It abducts the shoulder and it just said to,
Yeah, you did.
it internally rotates. Externally rotates.
Alright. So just remember those. You're
Mhm.
good.
Good, man.
Okay, so now wait a minute,
Oh,
I need
yeah.
you to palpate him.
Alright.
That's why we're here, Dean, so that you can get all those little bugs out, cause you know what you're doing. So now, whenever you are, going to palpate your patient, make sure you wanna always put them in the optimal position. Okay? What would be the best position for you to palpate the muscle and then possibly treat the muscle? Okay? Yeah. You okay, man?
Yeah, I was asking her if it was like,
Huh?
I was asking.
Oh, okay. All right, go ahead.
Hi, my name is Trevor. I'm going to be your therapist today. I heard you're having some issues up here in your shoulder, so I'm going to go check it out. I heard it's your supraspinatus, so it's going to be up in here. So what I'm going to have you do is I'm going to have you go ahead and put your arm straight out for me.
Okay, and how are you positioning his hand?
Let's get that thumb pointing towards the ceiling. There we go. So you first find the spine of the scapula, and it should be right above that. You can look for it going under the acromion as well, into, yeah, let me go ahead and put your arm back down.
Okay. Is this an optimal position to put him in? What would be a better position to put him in?
Gotcha.
Not the hand itself. Is sitting an optimal position, or would prone be an optimal position?
Prone, alright. So then, what I'm gonna have you do is we're gonna have you lay on your stomach right now, put your face right down in there. Gonna put something right underneath your legs here so they can rest a little better. Alright. So, once again, I'm going to look for the spine of the scapula.
Okay, is that the spine?
No, I'm trying.
So where would the spine be? If you had him sitting up and it's posterior to the acromion, where would it be lying down?
Posterior to the acromion, so right back in here.
It would be up higher, would it
Up
not?
higher.
Yeah,
Alright.
see? So it's good to know like where your bony landmarks are so that when you position them in a different way, you don't lose the landmarks. Okay? Because there might be a time, go ahead and sit up, Dee. There might be a time where that patient's posture is so bad that you want to put them in a different position in order to palpate. So you just want to know, like, is this a good position or is this a better position for you to palpate and then treat? Okay? Good job, guys.
That was not a good job.
We got this. We'll say more.
I was
Yeah,
trying.
Don't worry, we
you
got
got it, you
this.
got it, you got it. Okay, so now we went from supraspinatus, and we're still looking for issues that might be in the rotator cuff. Okay? So let's look at our teres. Let's look at teres minor. Okay? What does teres minor do?
External rotation.
Okay? Okay. So, let's see who I'm gonna take. We'll take you, Josh, and we'll take you. Yeah. She looked more excited. You were like, no. Okay. And she did really good, right? She's
Got it all the way up here.
it's like she has already worked as a CNA. I already know how to do that. That's good.
Okay, so
Okay.
my name's Abby and I'm gonna be your PTA. And I'm gonna be seeing what's wrong with your shoulder. So, we're coming infraspinatus? No, teres minor. Okay. So I'm gonna have you lay down on your stomach. Okay, with your face in here. Okay. So, and I'm gonna have you, can I do it on this way?
Yes, I'll have you do it on the other side.
Okay, so I'm gonna have you kind of, yeah, like that, okay? So, teres minor. So take this right here. Teres minor is right above.
Okay, what's your origin and insertion?
It inserts in the greater tubercle.
And it starts where? We're looking at teres minor.
2/3 of.
Is that gonna be superior, inferior? What part of the two?
It's superior of the teres minor.
Okay, we are doing teres minor, so is it above or below the teres major?
Above.
Okay.
So here. So I'm gonna have you put that. That's right. Okay. Go ahead and relax.
Okay, good job. All right, so, Josh. Yes. What's its nerve innervation?
C5, C6.
Okay, and another name for it?
And spondylosis? Let's start with the S. I'm not sure.
Do you know?
It is C5-6.
Axillary?
Axillary, right? No?
Okay, so I want you guys to make sure you guys learn those, okay? Because C5, C6 it goes a long way. C5, C6 could be deltoid, C5, C6 could be axillary, C5, C6 could be musculocutaneous. So you gotta be able to identify which area it is, okay? Whether it's the suprascapular nerve, you know, subscapular nerve, whichever one it's gonna be, okay? So make sure you guys know those. Okay, so now, was your teres minor tender, Josh?
When you palpated, I forgot, but I think it was just a little.
Just a little? Okay, so then what else would come up through around that same area? That's a rotator cuff muscle.
Teres minor?
You have infraspinatus, but this one's deep. Subscapularis. Okay, so we'll have Sarah and Sean. I got one for you, Courtney. I got one for you. Saving the best for last, right? You guys are doing really good. Okay, so. Oh, we switching?
What do you want to do?
What are you gonna do? So which muscle do you have?
Subscapularis.
Okay.
Hi Sean, my name's Sarah, I'm gonna be your PTA, and we're just gonna take a look at your subscapularis muscle. Okay. So that's part of the rotator cuff. So I'm just gonna touch right here, okay, because it's right there.
Okay, so where is the subscapularis?
It's like, can you feel it through the back? Underneath?
This, so its origin, Sean, is where?
The subscapularis fossa,
And it attaches where?
the lesser tubercle of the humerus.
Okay, so, what would be the best position to put him in? You're looking at something that's really deep.
Prone? Or?
You
prone?
wanna get the ribs out of the way, right? So what position would it
Can we be prone and look design like that? I don't know.
be? Okay, so go ahead and put him in the position that you think he should go in, and then we'll see, because it's kinda hard to get underneath. Okay, so what would be the best position if you're gonna do it like that?
Supine?
Okay. Come on the outside.
So it'd be like.
Yep.
In here. Under the scapula.
Okay, hold on. Because remember, this is not how you palpate, right? You go in deep, and it's usually tender. How's that feel? Oh. I said, how's that feel? He goes, oh, that hurts. So you don't want to take him all the way back. Relax, 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 relax. Relax your arm. Relax your arm. Relax your arm. Okay. So then you just come under.
This is your favorite
And it
one,
says
Josh.
that it's tender. So you watch your patient, and if he grimaces or if he moves away, or a leg comes up, then you know that you reached that point. But you have to push the ribs away. Okay. All right. But you have to relax, because the more you activate, no, you're not. Cause see, look, your whole arm up there. See. So, because when you activate here, you're going to activate that muscle. So you have to stay relaxed, because when you activate the muscle, it's going to make it hurt. Okay? All right. So, what nerve is that one?
Lower, upper subscapular.
Mm-hmm. What numbers?
C 5, 6, 7.
Are you guessing or are you not? Thank you. Okay. Any questions, Dr. Byrne?
No, it's definitely not wrong to do it in supine, but what I would do is lay back, have him go a little bit further away from you. You can have this hand kind of resting here if you like. Then you can use two hands to kind of get in there.
Way deep.
I don't like this position because it's a little awkward, right? So I'm gonna have Sean lay on this side, away from me, right? Because this is the shoulder in question. How do we make the shoulder pop, or the shoulder blade pop out? Yeah, internal rotation here, right? And if you come here, look how nice vertebral borders more exposed in this position. So you can really get under that scapula. Okay? And you can come from here too. You can come here.
Subscapularis.
Underneath, yeah. So you can
Coming
come
from the other border.
Rotator cuff muscle.
And you can even push your shoulder with your right hand posteriorly.
Okay, there you go.
Yeah.
This is the best way.
Yeah.
Push it.
For the practical, do you want us to know the numbers of the nerves, or just me?
Yeah,
Just
know
me.
the numbers.
Numbers too?
numbers and names, yeah.
So
It's gonna give
5,
you,
6, 7.
it's
plus
gonna give you a
axillary.
basis for, when you start doing the myotones. So then you already know what they are, okay? That's the one thing that Dr. Faroyan was saying. So next semester, when you go into that particular class to do neuro, that's what you'll have to already know. And so it's better to just start now, so that you don't have to be like, oh man, I don't know what those numbers are, I just know the names. You'll know the names and the numbers.
Yeah. The nice thing about having him in sideline is because you can palpate the subscapularis muscle well. You get your fingers under that medial border, you get up under it and palpate for tenderness. If there is tenderness and you reproduce their symptoms with palpation, then you don't have to move him anymore. He can be in sideline and you can treat the muscle in that position. So that decreases your positional changes for the patient. And you wanna make sure the patient's as comfortable as possible. So if you can just get him into one position, test, treat, and then reassess it in a similar position, I think you've done a good job with that person. Instead of having him supine, hey, can I have you go prone, hey, can I have you do this, that. I think the biggest error that students make on their practicals is that,
Is that
yeah.
going from one place to another, because you started out in sitting, and then we moved to supine, which is better than your sitting, but then the sideline was the best, because then you can get underneath the whole muscle.
So for kind of in that situation where Sean was in supine versus on the side, does it matter if he came in from the medial or the lateral side?
So gotta think about what you're palpating. So if you're supine and you actually rotate the shoulder, right, you're exposing not the vertebral border, but the axillary border.
Yeah.
And you're palpating that muscle on the opposite side that you would if you had him in sideline and you're palpating the medial border here. Where most people will have their pain is the insertional portion on the vertebral border. Now if you're palpating here and you're not getting much reproduction of pain, I've seen clinicians put the patient in supine and palpate it from the anterior this way, in supine, and they'll find tenderness that way. In reality, a lot of dry needling experts will dry needle the subscapularis in supine. They'll take the needle straight into that subscapularis muscle from the supine position. What they do is they grab the skin, they take the lat away, out of the way, then that gives them more space to get the needle into their subscapularis. Okay, so just
Because when Josh and I were palpating, definitely the lateral side was much more tender.
this side,
Yeah.
the medial border side,
No, the medial was
The
less, the lateral,
The
yeah.
lateral side.
The axillary side, yeah,
this was more tender.
yeah.
Then you have to ask yourself, am I confusing those symptoms with maybe lat and subscapularis? So there could be some overlap. So the real way to do this, if you're in supine and you wanna palpate the subscapularis, you actually have to grab the lat, pull it out, with your other hand, get in there and try and palpate the subscapularis. Cause if you're just going in there like this, you might be confusing
Okay.
those two muscles together. Now there could be tenderness with both muscles. You can have tenderness. with
Especially if the abductors aren't working, so then that means it's gonna shorten down all of those other muscles. It can't go into its full range, so those other muscles will become short.
Okay.
So, all right, good job. Okay, so now that leads us to our next one, which is latissimus. Okay? So Courtney, pick your partner. Who you want to go with?
Oh, it's okay.
Just pick someone. Okay. Let's see. You get to go with Courtney. And this is latissimus dorsi. So it's not that bad, but it's in the same area where his teres minor is causing some tenderness, where the tenderness of the subscapularis was for Sean, okay? And so, we have this muscle that's still in that same area that's either gonna overlap or underlap. So you get to tell me which one it is. If it's deeper than the teres minor, if it's superficial to it, and what it is in comparison to the subscapularis. Okay? All right, come on up.
Okay. Hi, Alyssa. I'm Courtney. I'm gonna be your PTA today, okay? So I heard you were just having some trouble.
Somewhat.
With your body on one side.
I like that. All over.
Okay, so I'm going to, they already kind of checked out your rotator cuff area, so I'm just gonna go ahead and check out kind of a lower area here. It's called your latissimus dorsi, okay? So I'm gonna go ahead and check that out for you today.
Okay.
So the insertion point of the latissimus dorsi is the intervertebral root of the humerus, correct? And then it also,
Where does it originate?
so it comes across like the scapula, like the bottom of the scapula.
So
correct?
what would that angle be called?
The inferior angle. And then it attaches to your vertebrae as well. So your
Okay.
thoracic vertebrae, correct?
Which lower?
What do you mean?
It says the lower what?
The lower six.
Uh-huh, and then what else? You got 3 or 4 of them.
Lower 3 or 4 ribs.
Uh-huh.
Anything
Yeah,
else?
so that's.
I like 11.
So this is the origin, all of that is the origin of the latissimus. And you have the crest of what? Okay, and then you said the insertion. Uh-huh, so that's good. So you guys have hit all of its borders, right?
Correct.
Okay, and so, what would be the, nerve innervation? Mm-hmm. Right. So the thoracodorsal nerve, and, let's see. What's his action? What does it do?
The AV duct.
Latissimus. Okay, so all of its origin is on the borders of the ribs and the spine, right?
AV ducts.
Right, and what else? And what else? So, if I'm coming down like this, what am I doing? Okay, so I'm coming down.
Oh.
What is that?
I did the
AD, right? And then I'm going to internally rotate, right? But what else do I have to do in order to?
Extension.
Yeah.
Just be extension or the hyperextension?
No, it's just extension.
Okay.
It's not like this, cause you get like 40 degrees, right? So hyper would be a bit, so it's just good.
Okay, so on the books, it sometimes says like the last 3 or 4 ribs.
Mhm.
Okay, so that or, what does that even mean? Like, does that mean?
Because some people don't have that floating rib. Last 3 or 4 ribs.
Oh, okay.
So some people might not have it.
Cause I was like, okay, is it either 3 or 4? You know, which one is it?
Yeah.
But now that you say
So-
that, okay.
So some people might not have that. So you guys got the origin, you guys got the insertion, we've got the action, the nerve. Okay, so now we get to palpate it.
Okay.
Okay.
So I know how to find it.
Okay, that's good.
Is that good?
Yeah.
Can I do that? first?
Uh-huh.
So I'm gonna have you lay on your back, please. Okay, and I'll pretend to put something there in your legs, okay? So I'm gonna go ahead and have you.
Did you do this already, Phil?
I did. You missed it.
Okay,
So go
I
ahead
just
and
need to
have
make
you-
sure.
My hands are cold, sorry. I'm gonna go ahead and have you leave your arm like this, okay? And I'm going to kind of push you this way, but I want you to resist, okay? So ready? One,
Uh-oh,
Sorry.
ticklish.
1, 2, 3. One more time. So this is back there. This is how Tiffany had us find it, at least in class.
You just relax your. If she comes out, we can feel it.
Sorry.
Okay, so get your hand here. Because that way you're gonna have her adduct a little bit, and then you can feel it popping. Okay, so now have her adduct a little bit. Go ahead.
Yeah, I thought I was grabbing that.
Yeah, you may have been.
Okay,
Okay, that's good.
that's good.
All right. So, good job on that one. Okay, so now, did you still feel tenderness there? No? Okay, we'll say no. So we know that we can rule out lats. So then we still have one more rotator cuff muscle, right? One more rotator cuff muscle. And we have how many more people? 3. We have 3 more people? Are we off? 2, 4, 6, 8, 10, 12,
No, we're missing one.
I think Rochelle's usually on this class.
Oh yeah, she's on. Okay, so Eminem. Eminem, Mary and Marlene.
Oh.
They knew.
I think it's the
Okay. Huh? Infraspinatus. That one's an easier one, right? So for our infraspinatus, what does it do? It's a rotator cuff muscle, so what else does it do?
Rotation.
Which way? Medial or lateral?
Medial.
Infraspinatus? Okay, so you did it first. You went like this.
Lateral rotation. External rotation.
Okay. So, we got lateral rotation, adduction, and what's its nerve root? Okay, so it's kind of like the same one for the supraspinatus. So it would be what? The supra scapular. And what's the numbers?
4, 5, 6. 4 and 5.
Just 5, 6?
Oh, 5, 6.
All right. So what's the origin and insertion of it?
Infraspinatus fossa.
And
And then the greater tubercle.
okay. Good. So can you palpate it?
And you can.
infraspinatus or supraspinatus?
Then be prone and then find, can you lay on your stomach for me?
Oh, no, go ahead, I just. That wasn't a cue, but.
So I find the spine right here and the inferior angle.
And where is it at in between?
Right here.
Because it sits along the entire portion, right? Okay.
So between the lower part of the lateral and medial borders.
Okay. All right. Good job. Okay. So now, we've done supraspinatus, infraspinatus, teres minor, latissimus dorsi, and deltoid and upper tract. So we have, let's see, you haven't gone. Are you the only one?
I think so.
Okay, come on now. Who wants to be his partner? Okay. That's because you haven't gone. I'm like, I knew it was somebody else. That was good, Tony. You were just gonna sit back there and be quiet.
I was reading my book.
You were reading your book, okay. All right, so let's see. What muscle could we give you? Let's do. Those are too easy. So then we'll give you teres major. That was an easy one too, but it's not so bad. Rhomboids are super, super easy. How about levator scap? Yeah, because we were talking about the upper tracts as him having or patient having difficulties with the neck and possibly into the shoulder. So, what is levator scap? Origin?
I don't know the right insertion is superior angle. Origin, I'm not sure.
Simple tubers.
Superior angle of what?
The scapula.
Okay, and then what else? It has two areas here, and then it comes up here. So what would it be? Okay, so if it's gonna elevate, and it's gonna come to this direction, we know that this is its origin, right? What would that be? It's gonna elevate.
Actually go back here.
Was it like on the medial side of the back?
It's on the medial side,
So
that's
it's
right,
about
medial border of the scapula. And it's between this is the insertion, it's between the superior angle and the superior portion of the spine of the scapula. So it's gonna fit on that little angle like this. Okay. So, right in here. Superior medial border, right in here. Because your rhomboids is here and here, and then this levator scap is right up in here. Okay, so it's gonna insert right there. So, but where is it in here? That was a hurdle, wasn't it? Okay. It's gonna be right in here. These are cervical vertebrae. You guys remember that? Cervical vertebrae? 1 through 4. And then the superior border. Huh? You remember that
I
now?
think, yeah, it's like, they don't all come up like that. It's like, one
Because,
comes up first. and-
one, exactly, so you got different fibers that's coming up, right? So, and then it's gonna elevate. That's its motion. What else does it do?
A lot of rotation.
Uh-huh. It's lateral flexion and rotation.
Lateral flexion, rotation.
Mhm. And then what else?
Cervical extension.
Exactly, exactly. Okay, and the cervical extension is gonna be both of them working together to take the. So if the person had initially, an issue with their upper tract going into extension, could it have been levator scap all along?
Yeah.
Cause we tested everything else, and some of those tender points could just be what they are. Cause anytime you come up underneath the armpit, you're gonna have tender points. So that could have just been it. And then the lateral border of the subscapularis didn't have any issues. And yet they still have that weakness. And so it can rightfully be just levator scap. Okay, so tell me, what is its nerve root?
I don't know.
Okay.
C1 through C4.
The nerves that go into it?
I don't know the name.
Okay, so we're looking at cervical, 3 and 4, and then dorsal scapular, 4 and 5 for the nerves. Okay. And now, show me how you would palpate on your patient.
Oh, no.
Mhm.
Let's see.
So you gotta do what you gotta do first.
Right. Hi Pedro, my name is Anthony, I'm your physical therapist assistant today. Let's see, we're gonna start from the prone. Go ahead and lie down your stomach, please. Bring your feet up, right back down. Mind if I go in here?
That's fine.
So I'm gonna start palpating, I'm gonna find where it starts with the scap here. And working here.
And what muscles
Just that.
that you might have to palpate through?
The upper tract, I have to get back because it's deep to the upper tract, so. Just like that.
But it's gonna be closer to what areas of the vertebrae?
It's gonna be closer to sort of the C-spine versus being, so,
Versus being just a band of flesh, it's
Mhm.
gonna be closest to the cervix.
so I should be working a little more immediately than towards the C-spine.
Yeah.
Okay.
All right, Dr. Karan?
The only advice I have for your practicals is to remove the clothing as much as possible. So the least amount of barrier that you have, the better. So in my opinion, I would dock you if you didn't take off the sweater. Because you have so much barrier there that your palpation fingers are gonna have a really hard time palpating the structure in question. Right, so the least amount of clothing that you have in the way, the better you're able to palpate. Of course, if you need to palpate and you need to treat the muscle, guess what? You're gonna have the patient get back up again, remove the article of clothing, and then you're gonna have to treat the muscle with whatever tools, your hands, manual therapy that you need. So, in my opinion, I always have them take off the article of clothing right from the start. I always ask, is it okay? Are you comfortable with removing your shirt just so I can get better access to that area? They'll say yes, or they'll say no sometimes, so I'm just gonna have to deal with whatever they tell me. But that way, you don't have to get them back up, hey, let's treat the muscle now, can you take this off? So you have them in the perfect position, you're testing the elevator, scapula. You palpate it, you found some tender points, you reproduced the patient's pain. Now I wanna treat that with maybe some soft tissue stuff, but you already took off the article of clothing, so you can just get right to work.
Yeah.
You know, how efficient that has to be in the clinic, especially a busy one, where you do all those right steps, you get them at the right position, they've already exposed the area, you're good to go. You test it, you treat it, you reassess it, and then you give them a home exercise program, they're ready to go, okay?
So when I walked in, I know what I'm gonna work with, because I already have his chart. I could have asked, Pedro, do you mind taking off your sweatshirt so I can work in there a little bit better? So I could have asked that right when I walked in.
Right.
Okay.
We always instruct our female patients to wear a training bra to the clinic. For a guy, it's much easier because you don't have to wear anything, you just take off your t-shirt. So, for your practicals, it's my expectation, I don't know how you feel, but I would like the skin to be exposed. And another reason why it's important to expose and see the skin is that if you guys notice, there's a particular mole there that looks abnormal. Remember the ABCs of looking at the skin and moles, right? A is for the, B is the border, right? Asymmetrical, right? The mole looks asymmetrical on the borders. The B, look at the border, see what it looks like. C is the color of the mole, and D is the diameter. So if you notice something on the skin that looks really fishy, you probably should instruct the patient, hey, there's something fishy back here. I don't know if you can see it, but I can feel it. The mole is raised too. You probably need to check that out by a dermatologist, right? You guys are dealing with not only the neuromusculoskeletal system, but also the integumentary system, which is the largest organ of the body. You might as well inspect it while you can, right? Because most likely you could save a patient if you notice something bad. Okay? That's just my take on it, but I could be wrong.
So you said for the practical, you want us to expose skin, like that's okay?
I think it's important to expose the skin, so if the females, if they can wear a training bra.
Yeah, cause I never had them do that before, but, they had on these shirts, so I just had them do it
Yeah.
according to that.
Or if you could take just one sleeve out,
Okay.
and palpate the area, I think that's best. And it's practical, I mean, you're gonna be having to do that in the clinic as well. If you're gonna do your hands-on stuff. Now, if you get in there and you're just doing exercise-based stuff, you don't really need to take off the clothing, right? But if you're gonna be treating it with manual therapy or soft tissue work, then you might wanna take the t-shirt off, right? It's up, it doesn't matter.
Well, cause this one, they're just doing palpation, we're not going into treatment
Yeah,
yet, so.
you don't have to,
But when we do Therex and we actually start doing treatment, then that's how it would have to be, proper draping, proper, positioning and placement, so that the female patients are comfortable when you're working with them.
There's such a cultural difference here versus where I was in Armenia. I mean, here you have to drape, you have to make sure it's okay, you have to ask for permission, right? You have to cover all your bases. In Armenia, I say, hey, I wanna look at your shoulder, and they just strip everything down. They're like, here you go. I'm like, I just needed to look at your shoulder. Why did you take your pants off? You know? It's just how it is.
I don't need that.
I mean, women and men, they're just free
They're just
about,
free, yeah.
taking their, and Italians are the same way, so,
Do you have family over there in Armenia?
well, all of them are here now, but that's where we originated from.
Yeah. Was this good, guys, for you?
Yeah, I like it a lot.
Okay, so we'll do it again next week, and next week it will be from the arm down to the fingers, okay? And then that should help get you, to the midterm.